Up? Up, okay.
Talk a little about gout. It's supposed to be in the big toe, but I've had it in a couple other places besides the big toe.
Right. Can you hear me?
Why is it? I'm not a king. I don't leave a fridge lying.
Gout, yes. Gout can affect any joint. It is classically in the big toe, and we call that podagra. So yes, it's classically in the big toe, but it could happen anywhere. And it likes to go where you've had injury before, or where you have, where you've had some wear and tear before. It can even be along tendons. It can be in the skin in rare cases, so it can go in a lot of places. And the biggest risk for gout is having a high uric acid level, because what gout really is uric acid crystals deposit in that area, and then your body creates inflammation around it. So you'll have those uric acid crystals there, and then for whatever reason, you'll kick off an inflammatory response and get that red, warm, swollen, horribly painful joint. It's not a fun time during a gout attack. So our targets for treating gout are to lower the uric acid to a point where you're not going to get those flares. And so we use medicines like allopurinol, which lowers the uric acid. There are new medicines on the market that do the same thing, but maybe in a slightly stronger way. But we still use the same allopurinol in most cases. But yes, it could be anywhere.
Well, I wanted to ask Dr. McGovern, does it make any difference who makes the parts that you put in there?
So the question is who makes the parts, and there are 4 or 5 major manufacturers of implants in this country. I prefer the company called McGovern Implant Manufacturing Industries because that's the best. No, there's 4 or 5, and they all have similar products. You know, just like you have a Mercedes, a BMW, an Acura, a Lexus. Which is better? They really all have the same products. It's the way a surgeon chooses the implants that they think are best for the patient is, number one, the implant has a good reputation. It's been around for a while, right? Because joint replacement's been around for 5 decades. And so you want one the design has been around for maybe even 2 decades. Because if somebody comes to the office and tries to say, look, doc, I got this brand new type of implant. It's got a flare here and a piece here. It's going to make your patients do way better. I say, okay, well, let's take a look and see how it does 20 years from now, right? Because we already have ones that are out there 20 years that are working fine. So we accept small changes in the design. And each implant manufacturing company competes with the other to have small changes that address a very competitive market. And I really don't see any one of these major manufacturers that have an advantage. So we pick an implant that has got a good track record clinically, and then we find an implant that has instruments that fit the way we do the procedure. For example, custom fit instruments, or even manual instruments that feel good in the surgeon's hand or that make sense with the way the surgeon operates.
How long have you been using the knee technique?
So the question is, how long have we done the custom fit knee replacement? We have been doing it for almost 3 years now. We've done probably about 650 of those types of knee replacements. We have done more at Exeter Hospital, believe it or not, than most places in New England. It's a technology that we embraced early on because in my operating room I had already begun computer-assisted knee replacement a long time ago. So this, with the computer in the operating room. So it was a natural transition to go from the computer in the operating room to the computer outside of the operating room. It's a technology that's been around now probably for 5 years.
Doctor, when you use the computer, and how long does it take between the computer image and the actual replacement?
Right. So the question is, when we get a CT scan to get a three-dimensional image of the knee, how long does it take to make the custom implant, the custom instrument, which is made by a three-dimensional printer, believe it or not, and it's about 6 weeks delay, which fits into most of our practices, because from the time we see someone and we talk about joint replacement to the time they're ready for the joint replacement is usually about a month, month and a half, because that's gives us enough time for folks to see their regular doctor, make sure their heart, lungs, and kidneys are okay, sometimes see a cardiologist, get a stress test, all these things that need to be done. The time is getting shorter and shorter, and it can be as short as 4 weeks. But right now it's between 4 and 6 weeks.
How long should you wait? How much pain should you absorb before it's time to come see you?
Yeah, so that's a great question. When is it time for a joint replacement? I mean, do you have to be in excruciating pain? Do you have to use a wheelchair? When is the time for a joint replacement? And it's hard, right? Because there's no measure that we have. We can't put up an x-ray and say, oh, it looks like this hip has got about 3.2 years left on it. We can't do that. Because what the x-ray shows us is the diagnosis. This is osteoarthritis. And then we say, okay, well, doctor, when do I need a joint replacement? I say, well, the time to get a joint replacement is when the pain is interfering with your quality of life. Well, and folks say, what does that mean? Well, you have to look back and say, what things did I used to do that I can't do now because of the pain? For some people, it's walking, right? For some people, it's like, well, I never go out to dinner anymore because I can't even get to the restaurant because it hurts. Other people, it's golf, gardening, travel. So it's a really individual thing. And so it's when folks say, look, this painful hip or knee is really ruining my life. That's the time to get it done.
This may not be in your realm. It's a question that you just answer yes, no, or maybe. What about shoulder replacements? What about shoulder replacements?
So the question is, what if...
Answer anything about a shoulder
Yes,
replacement.
the question is, what if you have a painful shoulder that's ruining your life? I say get a knee replacement. Then you won't worry about your shoulder anymore because it'll hurt so bad for a while as you recover from your knee replacement, then you'll forget now. It's a good question. Shoulder replacements work, right? I have a partner, Dr. Clark, who does shoulder replacements. And a shoulder replacement looks very similar to a hip replacement, and that is it's a metallic ball and a plastic cup. And they are popular, becoming more popular because the technology is advancing, just like in hip and knee replacement, right? But folks can put up with an arthritic shoulder for a longer period of time because we don't walk on our hands, right? So when we say, when's the time to get your shoulder replaced? Well, folks can put up with it for a longer time because even if the shoulder is painful, folks can still eat, brush their teeth, fix their hair, do things, especially with their other arm. So shoulder replacement continues to evolve and become more common. And the time to get it done is when the pain is so bad that it's interfering with life.
Thank you.
Talk about the reverse shoulder replacement.
The reverse shoulder replacement is a kind of replacement that we put the socket where the ball is and the ball where the socket is. So a shoulder is a ball and socket, like that, right? Now what happens is the only thing that holds the ball and socket together is a group of muscles called the rotator cuff, right? A lot of folks, by the time their shoulder gets arthritic, the rotator cuff muscles are no longer functioning. So they can't hold the ball and socket together. So some smart guys said, well, what if we, on the socket side, made a ball, and on the arm side, right, made a cup, then you don't need so many muscles to hold it together. So that's what a reverse shoulder is. A reverse shoulder replacement is for folks who have terrible arthritis, who do not have a functional rotator cuff.
Dr. McGovern.
I'll draw a picture for you.
Dr. McGovern, over the last year, we've seen quite a few articles in the newspaper about failure of hip replacements due to, as I understand it, flaking off of the metal in the ball, and it's caused a lot of court cases and all that sort. Can you comment a bit on that?
Sure. And I have a good talk about that, and maybe sometime I'll come back and talk about that. But the question is what about these metal on metal hips that are failing? The hips that I've shown you, right, were a metal ball and a plastic cup, right? That's the classic hip replacement, metal ball, plastic cup. Now, what happens when you think about it, what's the wearable part? The plastic. You know, why does a successful hip replacement wear out in 20 years? Because the plastic wears out, right? So folks about 10 years ago in this country, about 15 to 20 years ago abroad, figured out a way to eliminate the plastic and have a metal ball and an all metal cup, right? Approved in this country by the FDA in 2001. And so this is a metal ball and an all metal cup, no plastic in between. So you don't have any plastic to wear out. And when the metal wears out, it wears out so slow that it can never completely wear out. So this is an idea that was proven in the laboratory to be a hip that would last a really long time. So the goal was to use it in folks that would need a hip for a really long time, like guys in their 40s and 50s, right? Who are going to need a hip for another 40 or 30 years. And so it made sense, and in the laboratory it looked good. Now, what happens is the metal does wear, right? And when the metal wears, it releases tiny little ions of cobalt and chromium. It'll never wear out, but there's a certain number of people who have a violent allergic type reaction to these metal ions. Some people can tolerate them a lot, and some people can't. There are some implant devices that generate a lot of these metal particles, and some that don't generate hardly any at all. So what happens is, if you happen to be one of those people who is very sensitive to metal, and have one of the devices in that generates a lot of metal particles, you have the worst of two things, and what people get is a violent tissue reaction. There was one product that was taken off the market because of a manufacturing defect. And that's what generates most of those things that you see on the news. That really affects a very, very tiny little bit of this population globally. But because it's worrisome, it generates a lot of press. So, you know, all of us who treat young people with hip disease embrace new technology. And I, in 2003 to 2009, used metal on metal hips in the youngest people. Guys that had a terrible deformed hip from birth, who are still making their living jumping out of pickup trucks and feeding their family. I used metal on metal hips. And these days, because of the controversy of, well, who's going to be allergic to these ions and which hips are prone to generating a lot of ions, I haven't used them in many years. But they're still out there and functioning very well in most cases. It's a small percentage that have these failures, which are catastrophic when they happen.
Would you or have you, can you hear me?
I can hear you. I can hear you. I'll repeat the question.
Sorry. There you go. Would you ever attempt to do a knee and a hip on the same time?
Ooh. So the question is, would I attempt to do a hip and knee at the same time? No. You know, look, each one of those operations is a huge operation. And the safest thing is to do one, fully recover, and then get the other one done. When folks need both a hip and a knee replacement, whether it's on the same side or opposite sides, the traditional way to do it is to do the hip replacement first, recover from that, and then do the knee replacement. And you say, why in that sequence? Well, it seems like it's a lot easier to recover from a knee replacement if you've already had your hip fixed. So we fix the hip first.
Is there somebody here? Yeah, here you
I was wondering if I
are.
have arthritis in my toes and I've developed neuropathy. Is that related or?
Good question.
Good question, yes, so that can be pretty complex. A lot of times neuropathy can be something idiopathic, meaning we don't really know what causes it. But there are several different things that can cause neuropathy. One of the most common would be diabetes would be a common thing, vitamin deficiencies. Some cases, autoimmune disease and inflammatory arthritis can cause neuropathy. So unless you had a condition such as rheumatoid arthritis that's more inflammatory, I would say it's probably doubtful that the neuropathy is related. If you have more of a wear and tear arthritis, the neuropathy is probably a separate issue. Both can cause pain, obviously, and both can be targeted separately with different medications. Sometimes beneficial to have overview from a neurologist who can confirm what type of neuropathy it is, where it's coming from, and how best to manage that part of things.
Explain neuropathy.
Neuropathy, so neuropathy would be an irritation of a nerve. So you can get what we would call a peripheral neuropathy, meaning that the nerves on the farthest away from our main nerves in our brain and our spine. So nerves that are far away in our feet and our fingers. So carpal tunnel syndrome might be an example of a neuropathy, in the periphery, where sometimes people can get what we call a radiculopathy, which is the nerve roots coming out of our spine, the major nerve roots, causing things like sciatica, pain to shoot down the leg from the back. So neuropathy just is a term to say that a nerve is irritated somewhere along its path, and it causes pain, sometimes numbness and tingling, loss of sensation. So it can be difficult to feel your feet while you're walking in some of these cases where the nerves are irritated.
Years ago, it didn't tell you much about lupus or what you could do about it. Are there any new things about lupus and its treatment?
Yes, so lupus is a disease that is coming, a lot of new research. She's asking, are there any new treatments for lupus or new things on the horizon for lupus? So because lupus is a disease that affects so many body systems and it affects people in so many different ways, it's been a difficult disease to study. There is a new drug on the market called Benlysta, which is what we would consider a biologic medicine, or a medicine that targets proteins in the immune system and blocks the immune system. The drug has had, so in the trials where they used it, they couldn't use it on anybody with serious kidney-threatening lupus or lung-threatening lupus. They studied it mainly in people who had arthritis and rashes and things like that. And they found some modest benefit, but again, it's so hard to study it because lupus has so many different characteristics that it's a difficult disease to study. So
Still a conundrum.
it's approved by the FDA and people are using it now, but only in people with certain components of lupus. And the classic tried and true medicine we still have many patients on is something called Plaquenil, which was actually an anti-malarial drug, but it's very useful for inflammation in lupus. And we've been using that for years, and we're still using that drug. It does work very well, but we certainly do need a lot more help with lupus. Some of the more life-threatening complications, like kidney failure, which can result from lupus, we do have strong medicines that can target that. So it really depends on what's happening with your lupus. Yeah. Thank you. Yeah.
Has there been any advances that in the use of the broad antibiotic spectrum that's necessary when you have one of these operations? And I speak from the point of view of somebody with such an operation who had C. diff that was very serious and very difficult to cure. And I was just wondering, that was some years ago, and I'm just wondering if there were any advances in the surgery that affects the amount of broad spectrum antibiotics that are necessary.
Yeah, so the question is, you know, one of the risks of any surgery, and especially joint replacement surgery, is the risk of a deep infection, right? And so we use antibiotics around the time of surgery, before, during, and after the surgery, to try to eliminate the risk of a deep infection. Now, when you're on a lot of antibiotics, and many of you know this, it can affect other systems in your body. In particular, the kind of natural bacteria that you have in your gastrointestinal system can get altered. And once that happens, you're prone to other infections. One of them is called C. diff, or C. difficile. So an issue has arisen over the years in all of surgery and all of medicine that if people are on long-term antibiotics or high-dose short-term antibiotics, they can develop a different kind of infection, not at the surgical site, but in their intestines, right? And so we're in a little bit of a conundrum because we have to use antibiotics to prevent infection at the surgical site, but we don't want to produce a secondary infection in the digestive system. What's happened over the years is that people who are much smarter than me, infectious disease doctors who study how much antibiotics do we really need around the time of surgery to prevent an infection at the surgical site, have come up with this idea that, you know, it's really the dose that people get before the operation that prevents the infection. In the old days, and it might have been when you had it done, because I did it for years and years, is that we would give folks a big whopping dose before the operation, another dose during the operation, and then we'd continue the antibiotics for 3 days after surgery, right? Now people get one dose before the operation and usually only one dose after the operation. And it seems that minimizing the amount of antibiotics that someone gets prevents these other infections, particularly in the digestive system.
What about the probiotics?
Probiotics are another way to populate your digestive system with the good bacteria. So that's another way to help prevent digestive system infections.
If there are no other questions, I think we've learned, oh, we have another one, okay, one more.
Can you inhabit lupus?
Say that again?
In front of your mouth.
Can you inhabit lupus?
Lupus is a disease that is caused by several different factors. We believe that we don't even know all of the factors that come together that can cause it. Part of it can be genetic. We are seeing certain genes that can be linked with lupus, but that's not the whole picture. We think some environmental influences, and we're not sure what, can also affect whether or not you will get lupus. But oftentimes, the other disease that can have a genetic component is rheumatoid arthritis. You could have identical twins. One could have rheumatoid arthritis and the other not. So we know that it's not, some of the autoimmune diseases are really not entirely genetic, but there are components of it that can be inherited. And one of the reasons that we can make a diagnosis of lupus is with a special lab test called an anti-nuclear antibody. This is useful in making the diagnosis, but we have lots of other criteria that we use to make a diagnosis. So a positive anti-nuclear antibody can run in families. It doesn't mean that you'll have the disease of lupus itself, but you might inherit this ability to have this antibody in blood. This is a blood test that we would get to look into lupus.
I'd like to thank Drs. McGovern and Matson.
Thank you.